morning to most of you in the Americas. Good afternoon to those of you in Brazil and Europe. Good evening to those of you in East Africa. And last but not least, our Australian friends. I guess it's 3 o'clock in the morning in Australia, and here they are participating. This is the start of World Vasectomy Day week, which will culminate in World Vasectomy Day on November 20th. All events have been arranged by, you just saw him, World Vasectomy Day founder and CEO, the driving force behind vasectomy promotion worldwide, Jonathan Stack, and his production team, including, but not limited to, Deidre Smith in Fruita, Colorado, Sheila Gabea in Kampala, Uganda, Sheila Torres and Luis Reyes in Bogota, Colombia. I'll leave it to Jonathan, the most gracious man I know, to acknowledge the contributions of other staff members toward the end of the summit. Now, this summit is a first ever, inspired by our valuable exchanges over the Vasectomy Network Google group, by our annual vasectomy ski seminars, during which we meet face-to-face to share ideas and fun, and to advances in internet technology, which now allow us to come together visually as never before. And this is a real treat for me to see some of the faces behind those wonderful contributions to topics raised on the Vasectomy Network. The network was established in 2012 by Grace Shi, and what a contribution to the vasectomy community that was. I would now like to turn this over to my co-host, Michelle Lebrec, the foundation of much of our knowledge about vasectomy, whose contributions to our exchanges are so eagerly awaited by all of us. Michelle.
Thank you very much for your good words, Doug. I'm so excited this morning to see you all. It's a treat, really. Thank you to being there. You know, I like statistics. I'm not only a vasectomist, but also an epidemiologist. So I just looked to the to what we have in the network, which was founded, let's say, 8 years ago. And up to now, we're 534 members. So that's a lot of people. And I don't know exactly now how many people we are now online, but that's a very nice participation from this large group. We're coming from 31 countries, so it's really international. I have to say that there are some countries that are more represented, like United States, Mexico. We have many doctors from Mexico, over 80 doctors from Mexico. Canada, about 50. UK, about 50, the same. And Australia also, about 40 doctors from Australia. But United States, 150. And what is very tremendous is the number of conversations we had since the beginning of this network. Actually, we're over 1,000, about 1,300 conversations since 2012. So that's a lot of stuff. And I dream of the day where I'm going to get a student who will, as a research project, go into the network and do a nice comprehensive project to just to illustrate what we have and to get some new and fresh idea that we can work on. So that's very exciting. I just see Dr. Batista from Brazil who's coming in. Hi, Dr. Batista. Now I'll introduce our first speaker. He's probably very tired, Nick from from Australia. Actually, Nick is one of the father of no scalpel vasectomy in Australia. We'll hear more about him in a few minutes. But Nick, it's really a pleasure to have you with us. And you'll be talking about managing of infection. And you're a past members, actually. I think you entered the network in 2014. So you've been there for a long time. Thank you for your input. And please start your conversation.
Okay, thanks, Michelle, and thanks, Doug, and thanks, Jonathan. I thought I'd just bring up the topic of infection. It's been one of the very topical things on our network recently, and there's a few interesting things that I just thought we all should probably have a discussion about. Infection. Have we got the slides happening? Do you know? Jonathan?
Yeah, I think the slides, Luis, could you put the slides for, yep, here we go. Sorry, but there you go. Hey, Nick, you indicate to us as you'd like, and we'll go switching them, okay?
Oh, okay, just go to the next slide. Next one. Yep. So overall, I'll go back up one. So overall, the US stats say about 5% of people get a surgical infection. It's interesting that in England, the British Association of Urological Surgeons, they quote an 8% vasectomy infection rate. And they say it's actually higher in high-risk groups. Now, I know that this doesn't apply to Mike Henchy and the GPs over there, but it's just fascinating that the British Association of Urological Surgeons also quotes a 1 in 20 to 1 in 50 scrotal hematoma rate requiring surgical drainage. So I'm not actually sure what they're doing over there. The most reliable statistics I could get were from Michel just recently, and I think he quoted a 0.2 to 0.5, sorry, to 0.0, what is it, 0.5 to 2% infection rate after vasectomy, depending on how your cautiousness factor. So I've divided it up into 4 sorts of infections that we see. The first, they're pretty self-explanatory. So we'll just go to the next slide. Okay, so the easiest sort of infection we get after a vasectomy is skin and wound infections. And look, every first-year medical student knows the signs of infection, you know, pain, hot, swollen. Those skin infections, can you hear me?
Yep.
Yep. Those skin infections are really easy to diagnose, and maybe the only thing that would make it complicated, I use cetrimide and chlorhexidine, and the cetrimide component, maybe once every 6 months will give somebody a massive scrotal allergy and turn their whole scrotum into a sunburnt sort of area. It looks like infection, but it's just an allergic reaction. I just put some really obvious pictures there of a skin infection. You can see how it's thickening up there. Next slide. I think that's a slide that might have been a slide when it was starting off. And the next slide. Now that's when that infection was really well developed. And you can see that it sticks out about 1 centimetre to 2 centimetres from the normal skin level. It's actually bulging out, and it was actually rock hard, that skin infection. Next slide. So this is the more interesting sort of infection, and I think this is the one that will promote most of the discussion, and that's intrascrotal infections. They're pretty, the commonest story we get after a vasectomy is this unilateral increasing pain and swelling starting a few days after the vasectomy, 2 to 5 days. And I think the $64,000 question is whether or not this is due to infection. Now, we all know about risk analysis and ambiguity in medicine. So my risk analysis slide is the next one. Now I'm quoting Clint Eastwood here from Dirty Harry. So if you haven't been a fan of Dirty Harry movies, you must watch the movie to get the meaning of this slide. But this is the most important risk management slide for both the doctors and the patients. And I mean, I feel this internally when I'm seeing these people. Do I feel lucky when I say don't take antibiotics? And I say the same thing to the patients. Next slide. So my approach to these. My approach to these infections, if there's no redness or fever, I'll often try non-steroidal anti-inflammatories if they're not already on the anti-inflammatories. Can we go back one? I'll try the non-steroidals. If they've already been on non-steroidals, I'll add in some paracetamol. If you're down below the equator, I'd use acetaminophen if they're already on the anti-inflammatories. Now, occasionally we get a person that can't take anti-inflammatories due to getting asthma or some sort of other allergy to them. And in that case, I'll use prednisolone. Now, if there's any doubt as to whether it's infected or not, I'll try and review the patients, but many times that's not possible because I work from different sites and the time, it might be a Saturday night, could be any. So I'll often prescribe antibiotics if I'm unsure and possibly stronger pain medications. Next slide. Various hypotheses have been brought up recently. The main one that was recently brought up was inflammation due to thrombosed vein. However, as Michelle said in the group, if this is correct, then occluding the vas without fascial interposition should avoid that problem. It could be due to inflammation due to an alteration in the arterial blood supply, or some other unexplained autoimmune effect on the epidermis due to a degree of blockage, even if we do use an open-ended technique. And I'm sure there's other possibilities that people might discuss today. Next slide. The third sort of infection that's probably really important to bring up, even though it's extraordinarily rare, and I've never seen a case, and that's of necrotizing fasciitis, the proper name for Fourniers gangrene. And that is really commonly with surgery anywhere in the perineal, perianal or genital region. And it is a surgical emergency with a potentially high mortality rate. It's a mixed infection caused by both anaerobic and aerobic bacterial flora, including the usual suspects from the alimentary tract, E. coli, Klebsiella, skin bugs, strep and staph, and some anaerobic bugs and such as Bacteroides. Now, it's actually there were case reports of death from this, from vasectomy. So next slide. And there's even been a case report of a man that got it from just masturbating without having a vasectomy. As we know, most patients, once they've had a vasectomy, they blame anything below the waist, any side effect below the waist as being due to the vasectomy. And just my tip to avoiding Fourniers gangrene is consider adding metronidazole in cases of severe infections. Over the years, I've had a couple of guys that have had fulminating infections. It's just got worse despite using things like Cipro and Augmentin Duofort. And I've added in metronidazole and they've actually got better. But like I said, I've never seen a case, so it's got to be pretty rare. Alternatively, if all else fails, can we have the next slide? I think you have got to just channel Donald, and I think he can probably start with his more modern treatments. And next slide. Now, urinary tract infection was also mentioned in our group recently, and there's been a lot of isolated case reports. In fact, I've had a few cases in the last 5 years, and in fact, one led to litigation, but the litigation went away as UTI wasn't accepted as a recognized complication of vasectomies. But there's got to be something in that, because male patients just don't get UTIs for no apparent reason. And when they're in relation to a vasectomy, there's got to be some connection. I'm not sure of the mechanism of the infection or how it gets there. I find it hard to believe the bugs crawl up the tube after you've just used mucosal cautery at 800 degrees. And I just wonder whether there's hematogenous spread causing that. Next slide. So there's a whole lot of quoted procedural variables which we might want to discuss. Whether we wear a gown, sterile gown, gloves, cap, mask, how we get rid of the hair before the operation, what sort of skin antiseptics we use, etc. Next slide. There's a whole lot of health conditions I don't want to bore you with that compromise the immune system that we all know about. Diabetes is probably number one, immunodeficiency, distant coexistent infection, etc. Next slide. The American Urological Association says that you should only use prophylactic antibiotics if there are risk factors present, but then it goes on to say the presence of one or more infection risk factors doesn't necessarily require the use of antimicrobial prophylaxis. So that's what we call in Australia, when you have 50 cents each way on a horse race, that means you're betting it to get a win or a place. Next slide. Another form of prophylaxis is obviously to drink bleach, which we've found to be very effective for coronavirus. Next slide. So just to kick it off, I had a look at a few of the Cochrane reviews. There's no clear difference in infection risk following the use of disposable face masks compared with no masks. And in fact, before Corona, I wasn't a mask wearer or a hat wearer. There's no clear difference between different types of skin antiseptics on surgical infection risk. Although there is pretty good evidence that using chlorhexidine in alcohol compared to betadine is way more effective. Unfortunately, you can't use the chlorhexidine with alcohol on the scrotum, but certainly for washing hands between cases, chlorhexidine and alcohol seems to be the way to go. Cochrane Reviews is uncertain whether no scalpel reduces the risk of infection. And the next one doesn't really apply to us that much, although some people do close the wound with cyanoacrylate and sutures. So I think that's about it before we throw it open to discussion. Is there any other slides there? Next slide. Oh, these are just quoted principles for preventing surgical site infections. Next slide. And that's the study that I quoted about the chlorhexidine and alcohol giving a 50% reduction in bacterial counts on the hands compared to using betadine scrub. So next slide. And there's just a range of the antibiotics which you could possibly choose from. So I'm happy to throw it open to everyone for discussion.
Yeah, I'd like to just, we're going to call on a couple of people. I know it's going to be a little complicated, but if you raise your hand, but I know already there was interest in responding from the UK. I don't know, Gareth, James, if you would be so kind as to kind of, I know you had some thoughts about the situation in UK, maybe you could clarify.
Yeah, I just put them through on the chat. Over the last 12 years, I've compiled all our data that we get from our members of the Association of Primary Care. There's usually about 40 to 50 clinics that do that audit on a yearly basis. So out of the last 12 years, out of just under 74,000 vasectomies, we know of 904 reported infections. That equates to about 1.2% over that time, or 1 in 82 patients. That figure of 1.2 is pretty indicative over the last sort of 8 or so years. It's usually somewhere between 1% and 1.4%. But the thing to say on this, the limitation of this, is that only 24% of those given antibiotics were given antibiotics by the vasectomy surgeon. The rest of them were given by other medical providers, including GPs and nurse practitioners, who will just look at a slightly red scrotum and go, "Ooh, you need some antibiotics, here you go." So there is that element of it. That's really all I was going to say.
All right. Doug, you want to comment? we're gonna unmic Doug. I'm sorry. Luis, let's have Doug say something.
No, Gareth, I think that was great input. Thank you. We get patients who will sometimes call their primary or go to the ER because they just have that swelling that occurs after a vasectomy and they're put on antibiotics. I guess the ER doctors think they have to do something.
Yep.
I think there was a request to put up the slide. Chick Wilson is the next. Charles Wilson. Luis, could you undo his mic? Charles Wilson.
Can you hear me?
Yep. Mm-hmm.
Okay, great. I find this discussion fascinating. I do not know the mechanism of inflammatory response after vasectomy, but I am quite confident that it is in almost all cases not infectious, and I can say that on a basis of over 30,000 vasectomies where we've used antibiotics in a handful of patients. We see post-vasectomy inflammatory response in 5% of our patients. We tell our patients about it, we educate them about it, we recommend an anti-inflammatory regimen if they get it. And the most interesting thing is that it's almost always unilateral. It's very easy to describe and to identify. We almost always identify it, diagnose it, and treat it over the phone, but we always offer an office visit for any patient that's uncertain or concerned about it. And we treat it with full dose anti-inflammatories, usually Aleve, which is naproxen sodium, 1,100 milligrams a day, which is, if you take Aleve tablets, it's 2 in the morning, 1 at midday, and 2 in the evening. It almost always responds within 48 hours significantly. And then we keep that regimen up for 7 days minimum, during which time it goes away. And that's almost universal. Infections are very real and they're very scary. What Nick showed, and thank you, Nick, for that excellent review. What he showed was clearly a picture of cellulitis, not just a wound infection or superficial skin infection, but cellulitis with induration and edema under the skin. And that obviously it is an infectious process and needs antibiotics. But we have only seen that in a handful of patients. Less than 0.01% of our patients get infection. So while you can't wait for a positive identification of an organism to treat infection, and you have to treat it when you suspect it, I would encourage us to try to identify and diagnose this entity, which is post-vasectomy inflammatory response. Occurs generally between day 3 and 5. It could be day 2, could be day 9, but it's the bulk of those are between day 3 and day 5. It's very recognizable, and you can confidently not treat it with antibiotics.
We would let's give a little chance to Soon Lim, who's in London or in England, and he had some comments he'd like to add to the conversation.
Yeah, I'm just interested in Nick's slide, which talked about the presence of foreign body in the wound, because in the UK, we're not allowed to use the clips that Doug and Michelle uses for the fascial interposition. What I used to do was to use Vicryl, but I was aware of the fact that I was putting more foreign body into the wound. And some of my patients actually presented about 3-4 weeks after an uneventful vasectomy, having had no pain at all, with a sudden spike of discomfort at about that time. And the only thing I could put it down to was actually the absorption of the Vicryl material. I was just interested, I guess, in the worldwide as to how many people actually use clips and how many people actually use something like Vicryl, which then dissolved, and whether they noticed a problem then.
Soon, it's Nick here.
Hi, Nick.
I use clips and my daughter uses ties, Vicryl ties.
Mm.
We both get the same sorts of complaints. And look, I see that spike with clips a month later. Sometimes people randomly say, look, doc, I've been fine for a month and suddenly I've got this pain. And I think that's just a variation on this inflammatory response that we see earlier on.
Yeah, yeah. The other thing I've noticed is also the late hematoma. no problems at all. It's happened to a handful of patients. We're talking about single numbers in about 10,000, but somebody suddenly having a hematoma many weeks down the line is a little bit of a mystery to me.
I must say soon that I can see you and Mike Henchy there and Gareth, all of whom I've met, and that the stats that I was providing was from the British Association of Urological Surgeons. I'm not sure if there's any of those in our group, but they're their 2017 stats that they publish on their website, and it makes all of us look fantastic when we're doing vasectomies. So if you're getting depressed because you've had a few complications, I think all you need to do is look at the British Association of Urological Surgeons website and look up vasectomy, and you will feel great about what you do, because your complication rates will be way lower. Okay.
I think the problem with the British Association of Urological Surgeons is that urological surgeons now do hardly any vasectomies in the UK. So, and those that are being done by very junior staff within the hospitals. So, you know, they're bound to be less experienced than us GPs who do them.
And probably none of them are doing no scalpel either. They'll be doing the old-fashioned method, the butcher method.
Well, what is interesting is that when we get a really difficult case, we send them to these inexperienced surgeons to then carry it out, which is a little bit illogical. Thank you.
I'm going to interrupt just because time is of concern, and I wanted to take this time. I mean, it really, from Doug and Michelle and I, from all at World Vasectomy Day, one of the things we've been doing, really with the help of John Gilbo's inspiration out of the UK, is to start, a few years ago, we started creating awards to acknowledge the work of all of you guys. And I'm sure sooner or later, everybody will be receiving an award because you're all deserving. But we, you know, every year it's hard to choose, but we talk with Doug, I talk with Michelle, and, you know, it could be all of you, but I wanted to acknowledge this year, we really look for awards that people who distinguish themselves, who show kinds of a sort of a dedication to all of this that's unprecedented. And I wanted to give that award this year as innovation to Dr. Nick Demediuk, just for the fact that he woke up and made fun of America so well. He deserves an award just for that alone. But thank you, Nick, for all that you've done. We have a little video we would like to show, and then just give you a few moments to respond. So if we could put up the Nick Demediuk video right now, that would be wonderful. Of course, we have to make sure that everything's, oh, here it goes.
Oh, God.
There should be sound, but I'm not getting it. Well, there you go, Nick. Thank you so much for everything. I think there's a certificate. We'll have to let you to print it because we're not there. I think somewhere the certificate should come up. Thank you all. Let's just, I don't know if we have that certificate, because it'd be nice to show it if we can. And in the meantime, Nick, why don't you say a few words? We'd really like to hear from you.
Oh, look, I'd like to thank basically everybody, but look, I'll start off. My wife was in that first couple of pictures, and I've got to admit that she has had all the vision in my career with respect to vasectomy. She was the one that pushed me to dumping my normal practice and to just do vasectomies full time. And she's been the biggest supporter of me throughout my career. Unfortunately, she's got end stage dementia at the moment, even though she was involved at the very start of World Vasectomy Day in 2013. She really has got not a clue about anything at the moment. But the other people I'd like to thank, Doug and John and Ron and Michelle, for their input into my career. All the people I've met through going to the Philippines, you all know who you are. There's too many of you to mention, especially the young up and coming vasectomists. And I'd also like to thank everybody on the vasectomy network for sharing their problems, ideas, techniques. They've been fantastic. And also Jonathan, Deirdre, and all at World Vasectomy Day for promoting the cause. So thanks, everyone.